After the dentist has produced the cavity preparation, an assessment needs to be made of complete caries removal. In this example, we see some brown stain, which may or may not be hard or solid dentin. You might want to call attention to your dentist if you see an area of incomplete decay removal. We're a team. We want the best for our patients, so it's okay sometimes to talk about this. Of course, have a conversation with your dentist about these things discreetly. So we proceed from this to completion of removal of decay, and then we place a liner or a base into the cavity preparation using a die-cal instrument. Typically today, beneath composites, we're using the light curable Compomer or the light curable glass ionomer types of bases, or flowable resins as types of bases, rather than a die-cal type of product, or especially no products with eugenol, which are incompatible with composite. After the base is placed carefully, we cure the base with a light and make sure that we've removed excess from any marginal contact that the base may have come in contact with that would interfere with composite right next to the junction at, for example, the cavo surface margin. The cure time is prescribed by the instructions on the cavity liner. Please adhere to the instructions and find out what your particular product involves as far as cure time. And then the acid is placed. Typically it takes a little longer for the acid to etch the enamel than it takes to etch the dentin. And many dentists have a protocol of etching the enamel first and then allowing the material, the etchant, to flow onto the dentin. There is a prescribed etch interval. Some teeth are harder to etch. Some teeth have, you might say, a softer, less dense mineral formation and are quicker to etch. Follow the manufacturer's recommendations in the etching process and the times for etching of both enamel and dentin. It's possible to under-etch, and it's also possible to over-etch. Over-etching can produce sensitivity. Under-etching can produce a reduced bond integrity. Rinsing is also important. We follow the manufacturer's instructions for rinsing. The instructions may say to rinse for 10 seconds, or 20 seconds, or 30 seconds, but you should read your instructions to know how to thoroughly remove the acid layers and the acid gel from the dentin and the enamel. With complete removal, we get the best penetration into the etched surface. The etching continues through a time interval. Don't rush it. Under rinsing can produce a residual layer of acid that can remain to irritate the pulp. Also, under etching can leave a residual layer of gel which can interfere with bond strength. Now we see the etched surface. It's slightly chalky. We have dried that surface with an air jet, a dry air jet, and with the air syringe and the air drying, we need to consider how long to dry. There is such a thing as over drying, which can take out fluid from the dentin tubules and produce sensitivity. And there also is such a thing as under drying, leaving too much moisture in the surface, which will impede penetration of the resin into the dentin and enamel that's been etched. So there's a happy medium in drying. Discuss this carefully with your dentist and follow the manufacturer's instructions as to whether the air drying is 5 seconds, 10 seconds, probably not as much as 15 seconds, but that will be prescribed in the information pamphlets on the materials that you're using. The bonding agents you select are applied in a specific manner. It may be a one-step bond or a two-step bond. In these cases, you need to follow your manufacturer's directions. The bond is placed so that it saturates both enamel and dentin surfaces and then blow off the excess. And some manufacturers suggest that the bond be cured at this stage after we've blown off the excess and also dried away the ethanol, alcohol, or whether it may be an acetone-based product that may involve a different time in blowing the air to dry away the material that dilutes the resin. With the air drying and blowing away of ethanol or acetone that are the diluting vehicles in the resin, we now are ready to place the composite materials. The composite materials are placed in increments and not covering walls that oppose one another. We realize that composite shrinks, and as we're building these layers, we want it to, if it's going to shrink, it's going to shrink towards just one wall. So I like to place it on a lateral wall at a diagonal, and then using a condenser push the material into the cavity walls, and in this case it was shallow enough that we can come up to the cavo surface margin. And that material is then cured for a prescribed amount of time. Undercuring can result in further shrinkage in the next cure layer, so we want to get all of the shrinkage in the first layers cured completely, and that may involve, with your light, a 10-second cure or a 30-second cure. Probably not much longer than that, but you should know how long it takes to cure the particular material, and that's reading the manufacturer's instructions. It's also interesting to note that the darker composites take longer to cure because the light doesn't penetrate as deeply or as thoroughly through a darker shaded composite than the lighter shaded composites. For development of anatomy, we might use, in this case, the ball burnisher, and it depends upon the patient's own anatomy. Do they have sharp line angles, sharp triangular ridges, or is there a more cup shape in the wear patterns of the teeth? The shape of the teeth can direct as to what shape of either burnisher or what we call a premier carver could be used to develop the occlusal form of the occlusal composite. We go through the shaping and forming of the composite and removing of excess. By getting the excess off, it can reduce finishing time, and we can reduce the overall treatment time. Once the composite is completely cured, we also can check for occlusion. In this case, we've removed the rubber dam, and with the rubber dam off, we can now check with articulating paper. In this example, towards the central groove, we have a high spot. The patient's normal occlusion on the buccal cusps is apparent, and we'll proceed to adjust occlusion. Using a 12-bladed finishing burr, and in the state of Missouri, these are procedures that are to be performed by the dentist using the handpiece to adjust the composite and adjust the occlusion. The occlusion is normalized to the patient's habitual occlusion. We would like the composite to neither be too high or too short. In this case, we see the buccal cusp tips of the bicuspids and the molar have been worn and faceted, and we want to reproduce and harmonize the patient's own occlusion so that we have an equivalency of contact on the restored tooth with the patient's adjacent teeth. A final step can be performed of re-etching and resealing the margins, especially in those areas which have been abraded in the finishing with the handpiece. The re-etching process can then seal any little shrinkage areas at the cavo surface margin. Of course, we go through the same etch times and rinse times, and then dry, and then apply our resin sealer, blow off the ethanol or acetone to dry the sealer as much as possible before final curing. These are the steps for placement of the occlusal composite.